Okay, so just being mindful of the time, and we have a fair bit to get through this evening. It's 7:02, so I think we'll go ahead and get started, and people can continue to join us as they can. Good evening, everyone. Thank you very much for joining us this evening. My name is Brent Leonard. I'm a member of the board at Lupus Ontario, and I will be your host for the webinar this evening, along with Anne Brooks and Hadra Batul in the background, although you can see Hadra there too. The webinar this evening is focused on lupus and organ damage associated with the disease and treatments, as well as prevention. As we go through the conversation this evening, if you have any questions or comments, you can place those at any time in the chat or in the Q&A window. And also, if you have any suggestions for future webinars, please feel free to put that in the chat as well, and we will take that into consideration as we continue to plan events. Our distinguished guests will be familiar to many of you. Dr. Zahi Touma is joining us for the conversation this evening. Dr. Touma is a renowned clinician-scientist with a particular focus on identifying biomarkers that predict disease activity in lupus patients, and has been instrumental in the creation of disease activity measurement indices, such as the Systemic Lupus Erythematosus Disease Activity Index, or SLIDI for short. Director of the Lupus Program at the University Health Network, UHN, he has dedicated his career to advancing the understanding of lupus and improving outcomes for individuals living with the disease, and of course is a wonderful friend to Lupus Ontario. I'd like to take just a couple of minutes to provide an overview of this evening's event. In the past, our webinars have featured a PowerPoint presentation ending with an open Q&A session for all of you to join in. The webinar this evening will take the form more reminiscent of an interview and conversation without a PowerPoint presentation, but still with an open Q&A session at the end. The idea behind this is so that we can dive deeper into the topic of lupus and organ damage, empowering you with information to further support you as a patient on your health journey, as a caregiver, or as an advocate for a loved one with lupus. Of course, the webinar is not intended to diagnose you with organ damage. Everyone's health journey is unique. If you have concerns about your specific situation that may arise as we go through this, always reach out to your family physician or rheumatologist to talk about your specific health journey. With that said, let's dive into tonight's event. As mentioned, the topic of the conversation this evening is lupus and organ damage, understanding the impact and importance of early detection and prevention as well. To ensure we're all coming from a similar starting point for the conversation, allow me to provide some very high-level information about organ damage among lupus patients to get us started for just a few more seconds. Damage refers to a change in the structure or function of an organ or tissue started at the diagnosis of SLE, is present for at least 6 months, and is attributable to SLE. As many as 30 to 50% of lupus patients will develop damage at some point in their health journey, and both damage and disease activity can be measured on different scales. So with that in mind, let's start our conversation there. Dr. Touma, thank you very much for joining us this evening. As a rheumatologist, what does damage mean to you?
Good evening, first, everyone, and thank you for inviting me. So what damage means to us in general, right? So as you have mentioned already, Brent, damage, the current definition or the concept, the understanding of damage that we have is an irreversible change that can happen at any organ in our body, at the level of any organ. And it can lead to complete or partial kind of alteration of the function of a specific organ. And we always try and aim not to have any damage, because as you've heard already, it's an irreversible process, at least for now, the current understanding of damage. So we aim our treatment and we try to control the lupus activity to prevent damage.
And how does damage present? Is it more of an acute onset? Is it progressive over time? How does that kind of come about for individuals?
So it depends really on which organ we're talking about. I can give you an example, for instance, the kidneys. And as we know, lupus nephritis, or when the lupus attacks the kidneys, it leads to inflammation in the kidney, which is reflected by lupus disease activity. And this is when your rheumatologist will use, or your healthcare team will use prednisone and immunosuppressant to try to stop the inflammation and prevent damage. But in some cases, if this was not diagnosed early, or we haven't used appropriate medication, or for some reason the disease is severe and the current medication are not able to stop the inflammation, what's going to happen down the road is we lose part of the kidney function. And this can lead to something called CKD, or chronic kidney disease. And the more we lose of the function of the kidney, unfortunately, this leads in some patients to sometimes dialysis and kidney transplant. But even before reaching to the end stage of the kidney function, which leads to transplant or kidney dialysis, we define this into different stages, CKD 1, 2, 3, and so on, based on the level of the creatinine. And really, as we said earlier, we don't want to see damage because each of these stages can change significantly the life of the patient with lupus. So that's an example where things can happen slowly, and we need to stop it. But there are other example where it can be acute. An example could be if we have stiffness of the vessels of the heart, which we know as coronary artery disease or atherosclerosis. In some patients, this can lead to angina, which is severe chest pain related to the vessels, the coronary vessels, or myocardial infarction. This can be also a type of damage, but in this case, you will get acute. Literally within hours, you can develop a myocardial infarction. While as we heard earlier with the kidney, it can happen progressively in some patients, often progressively, but another can be also acute. So that's kind of two different examples.
And damage can take many different forms too, is that right? So for the skin, for example, it would be perhaps scarring. You mentioned the joints as well. Are there different kinds of presentations of what damage really can be?
Exactly. So in general, general approach, we divide our body into different organ systems just to help us map things and know what we're doing. So one of the major organ systems, as you have mentioned, an example is the skin, right? And skin manifestations are very common among lupus patients. And it's actually one of the first features that they can develop when they start developing lupus. And when we talk about the skin, it's the skin rash, or the butterfly that we see over the face, all the ulceration in the mouth that are usually painless. It doesn't hurt, but they are present there. Could be hair loss as well. So this is all still within activity. But after a certain time, if you don't stop the activity in the skin, in some patient, it might change. It might lead to change in the pigments of the skin, which we call either hypopigmentation. When the pigment of the color, we lose the pigment, and the area that's affected with the rash, it becomes a little bit lighter than the rest of the skin. And some people, they develop hyperpigmentation, where oppositely, it can become a little bit more darker than the rest of the body. And in some patient, you see a scar. Just imagine when you're doing something, if you cut your hand, you see a scar developing. So this is what we see in lupus patient with certain type of skin involvement, and particularly when you have something called discoid lupus, discoid skin rash, because the skin rash itself can be categorized into 3 groups: acute, subacute, and chronic. One of the chronic type is discoid. And unfortunately, discoid is notorious with the association of scarring. And if it affects the scalp, again, unfortunately, it might lead to some patchy alopecia, which is we lose the hair follicle, and that's irreversible damage as well.
Is it known if certain patients are more at risk for organ damage than others?
This is a great question. And yes, it is known. And we know the more the disease activity, if it's more severe, this can predict more damage down the road, right? Because the damage, we haven't talked about it as well. It can occur because of 2 reasons. It can occur because of the activity of the lupus, remember the example that I said earlier. If you have inflammation in the kidney and you don't have the right treatment or stop the inflammation on time, it leads to damage. But in certain cases as well, the medication that we use for lupus, and particularly what's the most important medication that we currently rely on it a lot, it's prednisone, because it works fast. And at the same time, it can be associated with significant level of damage. And I know we're going to talk about this later on. So this is why we divide kind of the damage into two major groups: things that are related directly to the lupus activity, the disease itself, and things that can result as an adverse event of the medication or different other factors. So this is why disease activity can predict what's going to happen down the road. So if a patient has a lot of organ involved when they are diagnosed or when they present with lupus, and that's reflected, you mentioned the disease activity score like SLEDAI, and the more you have activity, the higher your score is going to be. And the higher the score, predict down the road, we're going to unfortunately deal with more damage. So this is why it would be important to stop the inflammation if we can on the spot with the use of appropriate medication.
And you mentioned this quickly earlier, but damage is something that cannot be reversed. Is that right?
Exactly. Damage is usually irreversible. And this is at least the current definition that we have given for damage. And there is similarly, we talked about how we measure disease activity, and one of the tools that the physicians use in the clinic called SLEDAI. There is a specific tool that was developed by the American College of Rheumatology and SLIC. SLIC, it's a group of international lupus researchers all around the world. So they met together many, many years ago, and they developed an index called SDI, which is damage index. And it reflects the damage in different organ systems. But the definition of damage in this particular index, it's irreversible, right? But moving forward, you know, the damage index was introduced many years ago, and our understanding to the disease and to how the organ function, and we're hoping with the new medication, biological, that we have seen over the last 20 years, 2 decades for lupus, that we can change the pathway of how things evolve. And sometimes in some organ, when you have damage, maybe we can change this or reverse a little bit damage in certain organ. Okay, so that's kind of the future projection of how we're gonna how our understanding for damage will be evolving. And at this level, there is again a group of scientists working on how can we change the way we measure damage, and do we have to change it?
Just circling back for a moment too on the difference between disease activity and damage versus treatment and damage. If somebody's on prednisone, for example, and they're worried that this could over time lead to organ damage, is there another kind of treatment that could potentially replace prednisone? Does that open the person up to maybe more risk and increased activity?
Very important question. And I want to make sure here that we don't, it's important to understand still that prednisone is a very important medication for lupus patients. And in certain manifestation, when you have inflammation of the kidney or inflammation of the brain, you need a medication that can work fast. And at this level, at this time, one of the best medication we have is prednisone. But often what your medical healthcare team are doing, they start prednisone and they start as well Plaquenil or anti-malarial medication and different molecular immunosuppressant. But we know that immunosuppressant takes 3 to 6 months to start giving us benefit. This is why we bridge with the prednisone, because we know prednisone works really fast. Okay, but our current challenge with the medication that we have, and you all know these medication immunosuppressant, there are 3, 4 on the market: methotrexate, azathioprine, and Celsap or Myfortic. This is what we have at this level for lupus patient before the area of biologic. These medication takes time to kick in. They work well, but not for all patients and not for all manifestations. And often what we're doing with certain manifestation in the clinic, we start with one of these molecules, we wait a little bit, 6 months, and see if there is benefit or not. And we're lowering the prednisone at the same time. But we learn in a painful way sometimes that it's not gonna work. And what's the reaction of the team when the disease activity comes back again? They have to increase the prednisone. And you can see, and the patient asks you in the clinic, why you're doing this? We're doing this because we don't have tests to tell me your lupus gonna react better to molecule methotrexate or azathioprine or Salsep, and those are the medication that we have at this level. So this is why we go into this phase again and again. And also in some patients, no matter what we do, it's not sufficient. This is why we have seen a number of drug trials trying to bring new medication to treat the manifestation. And we have seen successful drug trials for biological treatment over the last 2 decades. I think we're going to talk about this later on as well.
So we talked a moment ago about measuring disease activity versus damage. So maybe let's revisit that again for a moment too. So I think everybody's fairly familiar with disease activity. If you're going through a flare for lupus, you know. When it comes to organ damage, it would depend obviously on what organ might be in play that might be at risk of being damaged, but are there kind of general symptoms or signs that people may look out for? Kidneys would be an obvious example. The heart was a good one as well. Are there other kind of signs depending on what organ might be impacted that people could look out for?
So exactly as you said, it depends really on the organ. And since we started the story talking about the kidneys, even when the kidney are inflamed and there is protein in the urine, the challenge with the kidney involvement that it doesn't hurt. This is why it's very important to periodically, when you see your rheumatologist, to do a urine analysis and check if there is any protein in the urine and treat it on the right time before it evolves into damage. So for instance, as you have mentioned, with the kidney, it doesn't hurt. But later on, when you advance with the stages of the kidney failure or the chronic kidney disease, it changed the whole body function. And you start getting probably swelling in the legs, swelling in the face around the eyes, and later on fatigue, anemia, and until it leads to dialysis. But there are organs as well where you can feel the pain and you know, okay, what's happening now in my hip or knees? So the knees can be affected by the arthritis from lupus itself. So when we have arthritis, it's often in our wrists, in the small, tiny joints in the hands, but it can be also in the ankles and the knees, rarely in the hips with lupus. But in some patients, when you treat the lupus activity, let's say you've used prednisone, Plaquenil, and methotrexate, and you know the patient is doing better and other joints are okay. But suddenly the patient comes to the clinic and say, my knee is swollen. Now after a year or 6 months from using prednisone, other joints are okay. So this is here where your physician will raise a red flag and say, why the knee are swollen? And this is something, if you've heard about it, it's called avascular necrosis. Avascular necrosis, it's a type of change that happens particularly at the level of the hips and knees mainly. We call it the joint-bearing, the weight-bearing joints, which are the joints that support our body. And often we see avascular necrosis in the knees and the hips. Now, depends on the grade. When you do an X-ray, you can grade how bad is the avascular necrosis. And unfortunately, in some patients, what happens with time when you have avascular necrosis, the joint itself can be destructed and collapse. And when this happens, you need to have a joint replacement. And that's a major thing. It's a major problem because the majority of our patients are young patients and below the age of 60. And you're saying at certain age, we have to replace your hip or knee. And we all know that knee replacement or hip replacement, when you have it can last for up to 15 years, maybe a little bit less, a little bit more. And can you imagine how many times throughout your life you're going to have the knee again and again replaced or the hip? So it's a major problem. And we have to start thinking about damage. And I know we're going to talk about it more, but always the physician, their aim is to stop the activity, which is great. But we always in the back of our mind think, what's going to happen in a year or 2 years or 5 years from now? or after 10 years. I'm going to see the patient in the clinic. They don't have lupus activity if we're lucky, but we end up with significant damage in different organ systems. So this is an example where sometimes it hurts and the kidney, it won't hurt. And there are many other examples we can talk about.
So that's actually a really good segue. Let's kind of stay maybe with the patient side for a little bit here and talk about patient-reported outcome measures. So the way really in which someone with lupus may be able to kind of indicate how they're feeling, what they're going through. And there are a couple of different questionnaires and indices to measure patient-reported outcomes. So maybe let's talk a little bit about those measurements, how patients can kind of go through that, what the questionnaire is like.
Absolutely. So, you know, patient-reported outcome are very important tools to complement the assessment when you see a patient with lupus. And when we talk about patient-reported outcomes, probably many of you have completed questionnaires when you see your medical team, whether about quality of life or about anxiety, about signs of depression. And there are tools as well about disease activity itself, where, so similar for the SLEDA, which the physician complete, there is similar tool that was designed for the patient, where the patient themselves can tell you where I have pain, where I have problem, based on their own assessment and understanding of the disease. Similarly, for the damage, which is the doctor use in the clinic, there is a damage tool, again, patient-reported outcome that was developed a few years ago, and it's validated for the use in lupus patient. It can help you as well and involve the patient to report on the damage that they're experiencing. At the end, all these aspects are important. What the physician is doing, the measure that we do in the lab and the imaging, and what the patient tells you. Now, I have to be transparent here. Are we very good with the patient-reported outcome? Not yet. There is no doubt that there's something needs to be done here. And ideally, I mean, patient who has been to our clinic, we do collect mainly patient-reported outcome for research purpose. But the future should be different. The future would be when we have a set of patient-reported outcome that can be completed before the patient comes to the clinic, and score generated that will be available for your medical team that they can look at and help you manage different things. And in some clinic, it's already implemented, because you have certain time when you see the patient, up to 40 minutes or an hour. And lupus can be so difficult sometimes that you're not able to cover all aspects. And this is not because we are ignoring other aspects, but we are dealing sometimes with major organ involvement, and we're trying to stop the inflammation, that we overlook other aspects that are probably more important for the patient.
That raises an interesting question as well. To what degree, if any, really does patient quality of life come into play when you're talking about treatment? So obviously, if somebody's going through a flare and something needs to be managed quickly, there are treatments that are stronger than others in order to do that. Does the conversation about quality of life play into kind of how this may play out in the future for somebody as well?
Absolutely. And the concept when we say quality of life or health-related quality of life, a lot of people say, what are you talking about? So quality of life, it's one of the tools such as SF36, which is not specific for lupus, and many people has completed SF36. Or there are tools that are developed specifically for lupus. One example could be the Lupus Qual. So they have a number of questions or items, and these items are grouped into different kind of domains. And one of them is pain. One of them is functionality, vitality. So when you complete this questionnaire, it gives an impression to the medical team about different aspects related to quality of life, your ability to do your tasks during the day, if you're feeling pain or not. How is the lupus affecting the image of the patient? And it's very important. Is the sleep affected or not? And all this is very important, because you can be doing the best treatment, you think, to treat the kidney, and the doctor is focused on, I don't want to see protein in the urine, and the patient is not sleeping all night as an adverse event from the prednisone. And we know it happens because it affects the sleep. then the patients think, what are you doing? You just made my sleep worse, and why should I take the medication? So this is why it should be a work team, and you gotta explain, prepare the patient, why you're doing this? What are the adverse events? When can we see an improvement? How we're gonna measure the improvement? There are things that the doctor has to measure, things that the patient has to measure, and things that both of them has to measure. And once you work together, the outcome will be better, and adherence to medication will be better. I need to know why you're giving me these pills.
If pardon me, if lupus damages an organ and then the flare recedes, will that organ always be at risk for future flares?
Absolutely, yes. It depends how much you have damage of your organ, okay? And I will go back to the kidney, and thanks for raising this important question. Because unfortunately, every time you have a lupus nephritis flare, you lose often part of the kidney. The kidney has number of cells that we are born with, and with every flare, you lose part of it. And the kidney try to hyperfunction, which means it's working harder to keep things okay. But it's gonna reach a time where the kidney said, I can't do anymore, and you will get into the chronic kidney disease. This is why our aim when we treat lupus nephritis, for instance, is to prevent flares down the road. And unfortunately, with the current medication that we have, we're not able to achieve this well, because we know in more than 40% of the patient, when we lower the prednisone on the current treatment that we're using, which is mainly Cellcept and Myfortic for the kidney, a large number of the patient go on and flare again. Not all of them, but the majority. And in some of them, no matter what we do with the current medication, we're not able to achieve improvement, recovery. But there has been a number of medications lately that showed benefit for the treatment, for instance, if we're talking about the kidney. So since the introduction of Cellcept and Myfortic that we've had now for many years, we've been using at least 20 or 30 years. One of the new medication, biological treatment is belimumab or Benlysta, which was recently, not over the last 3 years, the trial was published already and showed benefit if you add it to the existing treatment for patient with kidney problem. And there is another medication actually over the last 2 years called voclosporin. And it showed if you add these medication to the current medication that we're using, you increase your chances of achieving recovery. Not only this, with some medication, they showed as well that the risk of flare is less and less likely you're gonna evolve into chronic kidney disease. There is no doubt we need more studies to confirm this, but it's something positive already. And I don't know if you want me to get into the next part, which I'm gonna say, although these medication has been approved and shown benefit, unfortunately, we have been not able to use it for the lupus patient. And I'm gonna be transparent here in what I'm gonna say. One of the biological treatment, which called belimumab or Benlysta, which showed benefit for more than 10 years, only patients with good insurance plan are able to access the medication. And this is not fair. And new medication like voclosporin, and I can tell you now there is a number of biological treatment for lupus patient, and we need whoever is approving these medication to learn already that damage is important in the equation when we treat lupus patient, and we need access to biological treatment to change the trajectory of the lupus disease activity and stop damage. Rheumatoid arthritis, psoriatic arthritis, ankylosing, they're way ahead in treatment of lupus. They've had biological treatment for more than 20 years. Why, when it comes to lupus, we're not allowed to access biological in Ontario?
So that's actually a really interesting question too. So is there, on the treatment side, you've alluded to a few treatments, is there something that patients, their loved ones, their advocates can do to help speed up that process or get people more aligned to bringing these drugs through the pipeline, going through whatever trials need to happen and bringing them through to fruition so that people have them as part of their arsenal to treat their disease?
I think the patient can do a lot. And we have to empower the patient, and they have to be vocal as well about their disease, about their body, because I mean, the physician and the healthcare team is here to help and support, and Lupus Ontario and other organizations. But when it comes from the patient, it means a lot to the people who are approving these medication. So we got to work all together to change things, and it's time to get access for biological treatment in Ontario.
Kind of staying on the theme of, pardon me, of treatments, is there a difference in the damage severity at the time of presentation versus damage progression between patients who might be on steroids, for example, and patients who never were on steroids or other treatments?
Very important question as well, because there are studies that showed patient who you followed early from the minute they are diagnosed with lupus, and this is one of the studies that we have conducted at the University of Toronto Lupus Clinic, who were never exposed to prednisone. They still develop damage, and they can develop damage within the first year. Because we know if you have very severe inflammation in the heart or in the brain, it's gonna lead some level of damage, whether chronic cognitive impairment, whether involvement of the kidney function. But this, over time, we learned as well that continues to increase, especially when you can't control disease activity with the current medication that we have. Those are the patients who never been exposed to prednisone. And we compared it to a group of patients as well who are receiving prednisone. And what we found actually, that the level of damage actually is higher when you add the prednisone after a year, 2, and up to 15 years and longer. So the longer you live, the higher and the more you accrue damage if you are on prednisone as opposed to no prednisone. But we have to be careful here with what we're saying, right? Yes, part of the damage is related to prednisone, but also you use prednisone when you have more severe disease. And the severe disease is linked to damage as well. So not all of it is the medication adverse event, whether it's prednisone or from immunosuppressant can give infection and other type of damage. But also the lupus disease activity can lead to damage also. Another example about prednisone that might relate to a lot of patients, we didn't talk about it, cataract. So lupus patients, there are a high risk to develop cataract and have surgery for cataract early in their life because of prednisone. One of the adverse events of prednisone is cataract, diabetes, weight gain, low bone density, osteoporosis, fractures in your spine and other part of your body. And the list goes on and on with the damage that we get from lupus and the prednisone treatment particularly.
So how can we decrease damage? And if you're a patient, how can new drugs that have recently come online kind of change that trajectory for patients?
So, currently what we are doing, we have something called standard of care, which the way we have learned over many years to treat lupus patients. And as I mentioned earlier, we don't have a lot of choices. You have the 3 immunosuppressants that I mentioned, prednisone and anti-malaria treatment. And we've been working with the same medication for more than 100 years. We've learned that the patient are developing damage. I mean, just simply, if you look at this, don't you think it's about time to change the way we're treating lupus patients? Absolutely, yes. And this is why we have biological treatment. The important part of the biological treatment, and it has shown in many studies, it changed the trajectory of the disease activity, and it changed the trajectory of the damage. And if you want me to get more specific, if you allow me as well, there is a study where they compared the use of belimumab in patients from drug trial who received it for a long period of time, compared to the patient who are followed at the University of Toronto, where we think we're doing the best treatment at the academic center. But still, the patient in our clinic accrued more damage over time compared to the patient who were in a drug trial who received what we're giving our patient in our clinic, but they had access to biological treatment, which again, in Ontario, we don't have access to biological. And I'm saying Ontario, but it's not only Ontario, it's in Canada. So clearly, when you add the new biologic, you will change the trajectory of the disease activity, which means you might achieve faster remission. You will achieve more remission in a number of patients. And more importantly, and it's been shown clearly in the studies, that you will have less flare event down the road. And when you have less flare, you will lose less prednisone, and that means less damage down the road.
And I'm just looking at the chat here, actually. I think we've had a couple of questions come in. So one question that did come in that kind of ties in nicely to the conversation we're having is about Benlysta. And so are drugs like Benlysta being used for other SLE without kidney involvement? And also, is there research happening in that area?
Yes. So for instance, if we want to talk about Benlysta, which was approved more than 15 years now, initially it wasn't for the manifestation of lupus nephritis. It was for everything except lupus nephritis and central nervous system manifestation. But more recently, over the last 3 years, the new trial showed that it works as well to improve the outcome when someone has kidney problem. So with this medication, you covered a lot of manifestation for lupus, kidney and everything apart from the kidney. And also we did see recently a new medication as well that target different receptor for the lupus patient called anafrilumab or Safnello, which target interferon signature. And it's approved in Canada. It's approved in the state by the FDA, but it's at the level where now how much we're gonna pay for this medication and are we gonna pay for it or not? And again, only patient with good insurance, they have, for instance, as well access to anafrilumab or Safnello. So you've got two biologics on the market now for lupus. Belimumab, that's been for more 15 years and we can't access it despite many trials to approve the medication, and it's always been blocked. And the data is there and positive, and this is not acceptable. And the second medication is anafrilumab. It got, so at this level, anafrilumab passed the first test or filter, but we need to see who's gonna pay for this down the road. And same with belimumab for lupus nephritis, but not for other manifestation. So as I said, we hope that this gonna change. And if we look and see what has happened with different rheumatic diseases, like rheumatoid arthritis and psoriatic arthritis, they changed the life of the patient. And they showed already that they were able to stop the damage, because even with rheumatoid arthritis, you can still get damage in the joint. But when you use the biological treatment, the whole thing has changed over time. And we want to see this in lupus.
So I'm just cognizant of the time too, and I want to open it up to other people to join in with questions as well. So just a reminder to everybody to please put your questions in the chat and we can answer that. So with that in mind, I'll just kind of move a little bit, I think, to the end of our kind of structured conversation. And so obviously this is a pretty heavy topic. And the idea around having this conversation really was to empower people with knowledge around the kinds of organ damage that lupus can cause, as well as treatments. But the goal here really isn't to scare anybody with this information. What advice would you offer to lupus patients and their caregivers when it comes to organ damage, what to watch for, how to monitor, and how to have these kinds of conversations with their concerns with their physician?
I would say work closely with your medical care team. And it's very important that we learn about these things because when you go to the clinic as a patient and you know about disease activity and you've heard now about damage, the outcome are always better when we are all working together as one team. And a lot of patients actually in the clinic, they already know a lot about damage and they can help the medical team to say, I think at this level, what I'm feeling is more related to damage. So, and you work together with your medical team to achieve better outcome. So we should always provide education around different topics in lupus because again, as I said, it's a work team together.
One kind of follow-up question on that too, and then I'll open it up to everybody, is lupus can take many forms, we know that. And flares and symptoms can be confused with other things if you're a physician and you're not necessarily looking for lupus. Is there a way, if you're a patient, to kind of advocate for yourself, a better way to advocate for yourself, to say, you know what, I think this might be lupus, or this could be caused by lupus? How do you kind of navigate the health system or relationship with a physician to try to examine that path as a potential cause for your health challenge, rather than, you know, perhaps it being dismissed out of hand because it isn't a well-known disease among the general public?
So, you know, the CRA, or Canadian Rheumatology Association, we published all together, the lupus group, probably now more than 10 years ago, or around 10 years ago, guidelines on how to manage lupus patient. And we acknowledge in this publication that lupus is a difficult disease. And first of all, there is no doubt you have to be referred to a rheumatologist. And ideally, it will be great if you can reach out to a rheumatologist who has expertise in lupus. Or if your rheumatologist is not expert in lupus, or you've got manifestations that are severe enough, it's always great if the rheumatologists themselves can reach as well to lupus centers, and they can all work together. So I can give you an example. In the clinic in Toronto, and at the lupus clinic, I do work with a lot of rheumatologists in the community, and we talk among each other and we develop a plan together. And we even organize when I'm going to see the patient and when they will be seeing the patient, to make sure we're not overloading the patient with visits and blood tests. But again, here we come to the same question. We need to develop a plan with the patient, their location, their access to lupus center, and academic and community rheumatologists, and work all together.
Okay, so let's kind of end the structured portion of our conversation here this evening. We'll go to questions. I see there's a hand up, so we'll get there. I'm going to just go to one question that's in the chat first. And so the question is, it's perhaps a little bit broad. What are your views on monitoring mycophenolate levels in lupus nephritis, especially in non-compliant patients?
So, you know, there are different tests that you can do to measure the blood level of medication. There are tests for hydroxychloroquine, for plaquenil, and there are tests for mycophenolate or CellCept. They're accessible, and we do it sometimes in some patients. I think measuring the level is important, because sometimes it tells you you should give a little bit more, because we know in some patient, maybe 1 gram or 2 grams or 3 grams, I'm just giving an example here, it can be enough. And some people need more medication to reach certain level of the medication. So there is no doubt this can be helpful. But in terms of adherence, I don't like to use this word a lot, because I don't want to be policing the patient here, right? Again, we have to work together. And let me tell you, if the patient don't believe in the medication, whether you measure the level or you don't measure it, if they don't want to take the medication, they just don't want to take the medication. And this is where you have to work with the patient and see what is the obstacle, why they don't want to take the medication, and see how you can work together and improve the plan together, the adherence, if we want to call it, to medication.
And I suppose the trade-off is, if a patient doesn't want to continue a medication or is afraid of the medication for whatever reason, the trade-off is you may have increased disease activity, you may go down the path of organ damage, you kind of have all of those other cascading events that can happen.
Exactly. And if you might allow me to add here, because I'm doing a lot of research on cognitive impairment, and we know our brain has different domain and different functionality. And we know cognitive impairment is highly prevalent in lupus patients, probably around 45 when we're measuring this in the clinic. I think cognitive impairment as well can have an implication on the patient judgment sometimes. So this is why I don't like to blame the patient when they don't take the medication, because it could be truly that they're forgetting to take the pills, or there is issue related to judgment. There are different factors related to when we take our pills or not.
Okay, so we're going to go to a live question here. We're going to unmute, I hope I say the name right, Adlin.
Hello.
Hello, there you go.
Yes, good evening and thanks for having me. I am a person diagnosed with lupus just since late last year. But I have a problem. My rheumatologist has been out of commission for the past 3 months, which is Dr. John Acker. And I was referred to the Lupus Ontario clinic, which I don't get an appointment until the 13th of June. But I am due to do a colonoscopy test on the 5th of June. I'm just trying to find out, is it safe? Because Dr. Acker told me previous that any thing I'm gonna do, they should contact him first. Any procedure, anything, they should contact him first. I'm not able to contact any rheumatologist at the moment. So I'm just checking to find out if it would be safe for me to do a colonoscopy test.
So it's hard to answer individual question here, but I'm gonna just try to give an answer that every patient can benefit from it here. Colonoscopy itself, it shouldn't be a big issue if the lupus is stable, right? And again, it depends why the colonoscopy is being done. Is it part to check for the lupus activity, or maybe screening for a mass or tumor or something else? But in general, if the team decided to do a colonoscopy, I think they're aware that it can be done, and often it doesn't carry a lot of risk for patient with lupus to do a colonoscopy.
Sorry, it wasn't asked for by the rheumatologist. It was before they were trying to find out what was the problem that my family physician suggests that I do a colonoscopy. So it was after that suggestion that they realized it was really lupus. And I realized some of the symptoms of lupus is gastrointestinal problem.
A very important question, and we know lupus can affect any part of our GI tract or gastrointestinal system. And in some cases, we do scanner, we do colonoscopies or upper scope to see if the organ is involved or not. In this case, if they think the colonoscopy will help to determine if the lupus is involving the colon, then it should be done. I'm just giving here again a general answer, not specifically because I don't know all the details around your health.
Okay, thank you, doctor. Appreciate it.
You're welcome.
Okay, and I think we're going to go to, correct me if I'm wrong, Hadra, one other question that's live.
Yes.
To Heidi?
Yeah.
Thank you. Well, Heidi, we'll just work to unmute you here.
Hi there.
And there you go.
Can you hear me okay?
Yes.
Sorry
Yes.
for the noise.
okay.
My question is, I heard a comment Dr. Touma made, and it was about Benlysta and how we don't have access to it in Canada. So I may have misunderstood it, but I have been on it for many years. So I was curious what you meant that we didn't have access to it.
Very important question. What I meant there, and let me clarify this because very important, it's only accessible for patient with a drug plan. So if you don't, if the patient doesn't have private insurance, they will not be able to pay the cost for these medication and they cannot access it. That's what I meant by this.
Okay, thanks for clarifying.
You're welcome.
And we have another question in the chat. So can SLE with CNS involvement cause long-term damage?
You know, very important question. And I can tell you here, CNS, just to give the acronym here, is central nervous system. So, you know, our nervous system, we have the central and the peripheral. And always it's a challenge to make a diagnosis of the central nervous system when it comes to lupus. Because as you know, or if some of you have experienced some of the manifestation related to the nervous system, making a diagnosis can be challenging because we don't have yet the best imaging, the best specific blood test that tells us really there is inflammation at the level of the brain. So at this time, what we do is a scanner and MRIs, but all this can be normal, but this doesn't mean you don't have involvement of the brain. This is why you need to work closely in this situation with your rheumatologist, lupologist, and the neurologist and other specialties to make it the right diagnosis. And yes, it can lead to damage. And the cognitive impairment that I talked about, which we see it highly prevalent in lupus patients, maybe in some patients, there is some type of inflammation happening at the level of the brain that we're not able to measure it yet because we don't have the best tool and the best blood test. But we're hoping with time, there is a lot of research happening around the brain to improve our ability to make on-time diagnosis to prevent that damage that we're talking about.
And we have another question in the chat. Just give me a moment, please. So the question is, can you describe some of the symptoms of brain and lung damage caused by lupus? I think we had alluded to some of these earlier in the conversation. Maybe we can just revisit some of those symptoms for brain and lung damage again as well.
Okay, I'm going to talk about the lung, very important organ we didn't mention a lot. So what happened in the lung, we can get sometimes with the activity of lupus pleuritis, which is difficulty when we breathe and pain when we breathe, because the cover around the lungs is inflamed, and it could be also the cover around the heart is inflamed. We call it pericarditis. And also you can have inflammation of the tissue of the lung, right? And you treat this, but often in some patients, even when you treat, they end up with some scars at the level of the lungs or high blood pressure in the tissue or the vessels of the lungs. And this can lead with time to difficulty breathing, and you feel it when you're trying to do your regular activities and you feel I'm out of breath. I can't do what I was able to do in the past. So this is one of the features. If it persists, maybe there is some damage already that happened at the level of the lungs. Brain, we talked about cognitive impairment, and in some patients, it can lead to maybe sometimes chronic seizures and other manifestation as well.
We don't have any other questions just yet in the chat. We have a few minutes left here this evening. So if anybody does have a question, please do raise your hand or add it in the chat. I have a couple that I'll throw out there just to kind of buy some extra time for people if they're contemplating a question. And so is there research or is there a way to tell if someone has, for example, a history of stroke in their family and that person has lupus, and then that person has a stroke? Is there a way to differentiate whether or not something has been caused by lupus versus its family history? Mm-hmm. Does that make a difference in how you treat someone? Is it a research area that has been focused on at all?
Yes, very important question, because here in this situation, not just only the risk of lupus, you have the genetic risk, because there is some increased risk in the family for stroke. And when we say increased risk of stroke because of the family history, probably they develop early stiffness of the vessels, the main vessels that supply the blood to the brain, and it can lead to stroke. But lupus itself can give you as well stroke sometime, because what it does, it causes inflammation of the small vessels in the brain, and it can present as a stroke, or it can give you inflammation of the valves of the heart, and it leads to the formation of clots around the valve, and these clot can leave the heart and go into the circulation and reach the brain and give you a stroke. So in this particular case that you have just presented here or highlighted, the patient are at a risk of their genetic predisposition and the lupus. And it's very important to differentiate, because if you say this is lupus stroke related, you need to give immunosuppressant, prednisone, and anticoagulation. Where if you say this is it's from the heart or atherosclerosis, probably you're going to end up only with blood thinners and sometimes surgery to the vessels of the carotid, to vessels that supply the blood to the brain. So finding what's the cause is very important.
And just one other general question, really, it's more healthcare wide. I think probably everybody joining us here this evening is aware that there's a shortage in the health sector of physicians, nurses, across the board. If you're someone with lupus and you don't have a family physician, or you haven't yet been diagnosed and you don't have a family physician, and you go through the challenges that lupus presents, does that increase, not having that early diagnosis, does that increase your risk of organ damage down the road? And does it make it harder to treat once somebody does come in with an official diagnosis of lupus?
Yes, and yes, and yes. Yes to all of them. Because the longer you wait, it becomes more active and sometimes out of the control. And I always say, you look at the blood test and you see a storm there far. So you need to get ready, yourself and the patient, and use the medication at the right time to try to stop the storm. You don't want the fire to be really big, because you can't shut down the fire. And if you wait longer, unfortunately, as we talked earlier, we start developing damage. But if you don't have family doctor, you can sometimes just walk to any walk-in clinic and get a referral. And I know it happens. And I can tell you, when I see referral to the clinic, we screen the referrals and I read what's there to prioritize the access to the clinic. And not just only myself, all other rheumatologists do the same. You know, we talked a lot about damage, but I want to, if we can, because I see the time, we're toward the end, I want to say the future is bright, despite that we're talking about damage. We have at least now 3 molecules on the market for lupus. And in few months, you're going to hear again about more positive trial. So it's the best, we're witnessing now the best area for lupus in terms of drug development. And we're hoping that this is going to change our access to medication that we talk about. There is no doubt it's going to change. So hopefully we will get better medication to control lupus activity and damage. I don't want you to leave with just a bad impression, because hopefully we can change things.
And we are, that's a wonderful way to leave it. Heidi, I do see your hand, so maybe we'll take just one final question from Heidi, and then we will say thank you. Heidi, go ahead.
Hi there. It's actually not a question. It's just a positive end to the meeting that I was lucky enough to be on 2 biologics. I was on Benlysta and I'm now on Saphnelo. And I'm extremely happy about Saphnelo. It's changed my life. I know that it can work for some and not for others. So I'm not trying to get too many people excited about it, but I can go out in the sun and not get a rash. And it's been like that since I started. And I'm amazed, because it's been 30 years that I've had a rash on my face and now I don't. So I just wanted to say biologics have been really good in the last 2.
Excellent. And that is a wonderful way to leave it. It's a good news story. And, you know, who doesn't want to leave such a intense conversation for some people on a happy note, on a high. So thank you all for joining us this evening. I hope this was beneficial to everybody. Again, if you have any comments or suggestions for future webinars that you'd like to see, feel free to email us through the information that's on our website. Get in touch with us through social media. Dr. Touma, thank you so much for the conversation and for joining us and taking the time out of your evening as well. I certainly enjoyed the conversation, and I truly hope everybody else did too, and you.
Thank you for inviting me again. Have a good night.
Thank you very much.
Perfect.
Bye-bye.
Thank you, everybody. Thank you, Anne. Thank you, Hadja. Have a good evening.